80-year-old female patient, following a mechanical fall after 2 weeks, presented with reduced consciousness, open eyes to pain, make incomprehensible sound, and withdraw to painful stimuli. What's the patient GCS?
The GCS of the patient is E2, V2, and M4. The total GCS is 8 by 15. By 15,
Okay.
yes.
You have a patient with GCS of 8. What would you like to do now?
I would like to approach this patient based on ATLS protocol, starting with airway. Since the patient's GCS is 8, I would like to intubate the patient and secure the airway, following which I'll go for breathing circulation. And I'll also involve neurologist, neurosurgery, anesthesiologist, and proceed on to do CT.
Yeah. So first of all, you said you're gonna follow. Well done. You made your answer really short, which is good. You said I'm gonna do a full A-to-A approach with this patient, secure the C-spine, secure the airway, get anesthetist to intubate the patient, and make sure the patient is hemodynamically stable, has 2 wide pore cannula, resuscitation started, and then take the patient to CT scan after the R staple and speaking with neurosurgeons. Perfect. Well done. Okay. What are the main findings on the following CT scan, given that you said you want to do a CT scan?
So this is an axial CT, axial slice of CT brain, and it has got a right crescent-shaped hypodense area with mass effect and signs of increased ICP, that is mass effect, midline shift, compression of the ventricles, and effacement of sulci. And also I can see some air which shows pneumocephalus.
Okay, so you don't really want to say that this patient has increased ICP because you don't know if the ICP is increasing. You will never know until you insert a probe and then measure the ICP. Okay,
Sure.
you can say that there is a mass effect.
Okay.
Okay, and the mass effect is always 3 things: displacement of sulci, compression in the ventricles, and midline shift.
Midline shift.
Yeah, so but well done. Axial cut CT scan showing a right hypodense, crescent in shape, subdural hematoma with a bit of acute blood as well right there, and some pneumocephalus, causing mass effect, compression in the ventricles, effacement of sulci, and midline shift of more than 1 centimeter. All right. Okay. What does the loss of gray matter suggest?
The loss of gray matter suggests that the injuries to this area suggest that uh, there are high risk of having long-lasting cognitive disability as the nerve bodies are injured.
Correct. Yeah. And what's the management of subdural hematoma in that context? Patient with extradural hematoma with GCS of 8, you said how to manage A to E. I'm just asking about the specific management of subdural hematoma.
Management of subdural hematoma, it's a surgical emergency. It requires urgent decompressive craniectomy, and also we can admit the patient in ITU, monitor the ICP, and take a CT scan, monitor ICP, and based on CT scan findings, if the diameter of the bleed is more than 1 centimeter, or if there is more than 5 midline shift, the patient warrants an emergency surgery. And if the ICP is constantly more than 20 Hg, the patient will go on for go to the operating room for decompressive craniectomy.
Okay. So all right, that's fine. Jay, so in this scenario, you have a patient with GCS 8 and extradural hematoma. Are you going to think of taking them to ITU and waiting, or are you just going to take them to theater and operate?
Take to theater for decompressive craniectomy.
Yeah, so the cause is very obvious. You have a patient with drop GCS, subdural hematoma, and they might have had seizure, I understand, but you need to take them to theater, evacuate the hematoma, and then admit them to ICU and think about management. Okay. What are the advantages of a tracheostomy tube?
Advantages of tracheostomy tube includes it helps weaning from ventilator, and easier to clean the mouth and face, allows the patient to swallow, and the ability to eat. So there's less dead space and less chance of aspiration, less risk of aspiration. Sorry, and, that's it. So.
Yeah. So in terms of that, so it's easier to clean. You want to mention that as well. Less of aspiration, like I said, less dead space and better tolerated by the patients, and help weaning ventilator and allow the swallowing and ability to eat. Okay, that's fine.